Good day. This is your head and neck surgery module, which will deal with masses in the neck. So, for patients with neck masses, they are usually great in number in the outpatient department, ranging from the pediatric to the geriatric age groups. They rarely present as emergency cases, so you rarely see them in the emergency room. So in that small area of the neck, you have a lot of structures there. That's why you have a vast differential diagnosis when you see patients in the outpatient department. So for me, it is best to understand the anatomy of the neck by heart for us to be able to reach a very good diagnosis and manage patients well. So how do we approach masses in the neck? So as in any patient that you see with masses, you have to have a very good history, an equally very good physical examination. Aside from that, you have your biochemical, radiologic procedures, as well as biopsies that will help you arrive at a very good diagnosis to be able to manage these patients well. So that small area of the neck is divided into two major triangles by the sternocleidomastoid muscle. So the anterior triangle is bounded by the angle of the mandible, the midline of the neck, and the anterior border of the sternocleidomastoid muscle. And the posterior triangle is bounded by the posterior border of the sternocleidomastoid muscle, your clavicle, and the anterior border of the trapezius muscles. So the anterior and posterior triangles of the neck are further subdivided into smaller triangles. At the posterior triangle, you have your occipital triangle, you have your supraclavicular triangle, and you have the anterior triangle, and the anterior triangle of the neck is further subdivided into your submandibular triangle, submental triangle, your carotid triangle, your muscular triangle. So why are these triangles important? Within those triangles of the neck, they contain important structures. So your carotid triangle will contain your carotid artery, your internal jugular vein, and your submental triangle will contain your sublingual as well as your submandibular glands. So more or less, when you see masses in these areas, you might be able to have a more or less a diagnosis of the source of those masses in that area. So if you have an enlarged mass or a mass in the submandibular triangle, probably these are the lymph nodes in the submandibular gland or the submandibular gland itself. Now, if you have a mass in the area of the carotid triangle, these can be lymph nodes in the area of the jugular chain, or there might be also be a pathology in your carotid artery. So why do we need to know these structures? Because it will again help us arrive at a very good diagnosis. Now, what else is important? In these areas, you have what you call lymph nodes. So lymph nodes are actually structures that will drain fluids in the body or help drain fluids in the body. It is involved in our immune system. And of the 800 lymph nodes in the body, you have around 200 to 300 in that small area of the neck. And sometimes, this is the only presentation of a malignancy in some other areas of the body. So to give you an example of the nodal basins of the neck area, so if you see an enlargement in the submental triangle, this might be there might be a tumor coming from the areas of the anterior two-thirds of the tongue, the floor of the mouth, and the cheek, except for the cancer of the lip. It's similar to the submandibular triangle. Now, if you see enlargement of lymph nodes in the midjugular chain, you will now start investigating the areas of the oral cavity, the pharynx, the larynx, or in the Waldeyr's ring, your nasopharynx, the tonsils, and the base of the tongue. Now, in your anterior cervical triangle, probably when you have an enlarged node there, probably the major source of this node is a thyroid gland. So, when you see enlarged lymph nodes in these areas, more or less, you will be able to predict the possible source on why these lymph nodes are enlarged. So, what else is important aside from knowing the anatomy of the neck? Again, as mentioned, it is best to take a very good history. So in the history, what should be included? The age, of course, the location of the mass, the duration, how long has the mass been there? 20 years, 15 years, 3 months, 4 months. Is there a change in size from the moment it was noticed? How fast the change was from the moment it was noticed to the time that the patient came or visited you at the clinic? Is there a smoking history? Is there a history of radiation? Is there a history of travel? Because the source of the enlarged neck nodes or masses in the neck might be infectious. Is there a history of malignancy in the family? Now, what is worrisome or what are the red flags? So, if you find that you have a hard and fixed mass, it is rapid in onset, you have hoarseness as an associated symptom, you have difficulty in swallowing, you have weight loss, you have night sweats, and you have nerve deficits. Next is physical examination. So when you conduct your physical examination, you make sure that you wear the proper level of protection. So especially in this time of COVID-19. So before you do anything to the patient, you introduce yourself. You explain the process, why this needs to be done, and what you are going to do. So you secure the consent from the patient and you position your patient properly. So what is the goal of the physical examination? Is to get a very good description of the mass. In head and neck a physical exam, you only need 3. You have your inspection, you have your palpation, and you have your auscultation. So in the physical exam, you need your 5 S's. Where is the mass? What is the size of the mass? What is the shape of the mass? Is it rounded? Is it well delineated? Does it have borders? Irregular borders? Can you see skin changes on the area of the mass? Does the patient have any previous scars? What is the consistency of the mass? Is it hard? Is it soft? What is the temperature of the mass? Is it warm? Is it normal? Because if it is warm, then probably you are dealing with an infectious cause. Do you need to do transillumination to see if the mass is so big, to see whether this mass is cystic or solid? Is the mass pulsatile? If it is pulsatile, do you hear a bruit on auscultation? So after you have done your history and physical examination, then you decide on what kind of procedures you would like to do or you would like to request for, so that when you send the patient out from your clinic, you probably should have a working impression. So before you decide, what are you thinking? So what is your diagnosis? What will you tell your patient? So to help you in your diagnosis, or to help you in getting to a very good diagnosis or probably a very good working impression, probably you would need ancillary procedures. Ancillary procedures will include probably an ultrasound, because it is cheap. In some of the clinics of my colleagues, they already have an ultrasound at bedside or at the clinics, so it can be done anytime. It is reader and user dependent, so sometimes you'll see different, or not really different, probably some variables in the readings of ultrasound that you see in the outpatient department. And if it is safe enough for you to do it, you can do fine needle aspiration or a core needle biopsy guided by the ultrasound. Further, you can request for a CT scan or an MRI. Now, the difference is that with the ultrasound, this gives you a more detailed description of the mass. It is more expensive compared to an ultrasound, but this will help you assess at the same time the resectability of the tumor should there be a need to do surgery. So aside from that, you might need special tests like an endoscopy, especially for patients who might end up with a biopsy wherein you will decide that you need to investigate other areas of the head and neck to rule out any tumors that might also be present that we call synchronous tumors. Probably if you're entertaining a thyroid nodule or a mass in the thyroid gland, you will need a thyroid scan to help you determine the activity of the mass. And if on physical exam, you have a pulsatile mass with a bruit on auscultation, probably you would need an angiography to help you delineate, or to help you, or to guide you on the specific site of the mass, and to help you plan for the surgery. And on the pathology side, probably as an ancillary procedure, after you have ruled out that this is not a mass coming from a vascular source and that it is safe enough for you to do a biopsy, probably you can do a fine needle biopsy, a core needle biopsy, or an excision or an incision biopsy in cases where you have patients whom you are highly suspecting that this is a lymphoma. Because when you have patients who are suspected to have a lymphoma, you need a bigger tissue for you to arrive at a diagnosis of a lymphoma and to be able to differentiate what kind of lymphoma your patient has. So further, you might need biochemical studies if you are entertaining a thyroid pathology. You can have a T3, a T4, and a TSH. But for patients who present with anterior neck masses, of which the source is a thyroid gland, wherein you do not have any other symptom, just a mass, there are no signs of hyperthyroidism, then probably a TSH will be enough. Going further, after you have all these ancillary procedures, the patient now goes back to you in the clinic, shows you all these tests. So when the patient shows you all these tests, then you now start deciding on what to do with your patient. So this will now help you plan as to the treatment of your patient. So the treatment is basically dependent on the diagnosis that you arrive at. So if it's a benign tumor, then if it is not causing a lot of problems, probably you can choose to observe. But if you have symptoms like of obstruction or for cosmetic reasons, then probably your patient can go for surgery. If it is a malignancy, it is best to activate a multidisciplinary team. Now, what is a multidisciplinary team? Multidisciplinary team is composed of different specialties that will help you in managing your patients. So it's not just the surgeon alone. So it's not just the activity of the surgeon, but you also have other specialties that you need to discuss with to help you in managing your patient. So a multidisciplinary team might be composed of an endocrinologist, a plastic surgeon, your anesthesiologist, your psychiatrist or psychologist in case you really need to take out a big tumor that will help, or you need to take out a very big tumor that the patients need to be comfortable with the results of the surgery, especially if you have a debilitating surgery after. And all nutritionists who will help you in before, during, and after the surgery, just in case your patient might need an alternative form or a different form or a different way of eating, a different way of sourcing nutrition. So also, the multidisciplinary team will help you decide as to the kind and the extent of the surgery that you need to do for patients. So rarely these days do we approach masses without consulting other specialties. So it is not just surgery who will manage the mass or in patients with, especially with big masses. And also the multidisciplinary team will decide whether these patients should go for treatment prior to surgery or is there any treatment after surgery. So thank you very much. Should you have questions, you can send an email which I will post after this presentation. Thank you very much and may you all have a good day and stay safe.